Thank you very much, Alyssa. It was an excellent presentation, and we thank you all the time for all the work you do for all the patients. Next, we have Natasha Wolfe. She's Assistant Professor of Internal Medicine and Pediatrics here at the University of Pittsburgh. She's going to be presenting on lifelong surveillance of the aorta patient.
Hello, everyone. Thank you for inviting me to speak today. So I have the pleasure of being the last talk of this conference. So I stand between you and the rest of your Saturday. So I will try to be as succinct as possible. But this is an important topic. It's on lifelong surveillance of these familial aortic patients. And there's a lot to cover. So we're kind of going to do broad strokes to cover everything. So first, natural history. You've probably heard this many times already today, but the aortic diameter correlates with rupture, dissection, and mortality. The larger the aneurysm is, the faster it grows. And here you can see that these familial aortopathies like Marfan's or bicuspid valve grow at much faster rates, generally, compared to those in kind of the sporadic patient related to age and atherosclerosis. So these patients, the importance is to screen them lifelong and closely to catch things before things go awry. So imaging options, there are quite a few. We first often think about echocardiogram as kind of a screening tool. It's widely available, it's portable, it's easy to get done, but in some of our patients it doesn't give us good windows. Usually you can only see the root, and if you're lucky, the ascending aorta. And so it has limitations in kind of accurately assessing their full aortic pathology. Transesophageal echo is another option. Usually the windows are much better. You can see the whole course, but obviously this requires some sedation. It's a procedure, and it's more of a big deal for a patient. CT and MRI are really excellent modalities with good spatial resolution. We can see the full aorta. You can see them in multiple planes, which is a benefit for getting more accurate dimensions. CT in these patients who will be usually screened at least every 2 years can give you a lot of radiation over the course of your life. And so often we want to save them that radiation and use MRIs instead. However, MRIs are less widely available. They're longer studies. So each have pros and cons. And then also, as was just mentioned actually in the last talk, CT or MRI, there's no real guidelines on how you should report the measurements. So sinus to sinus versus commissure to sinus. And so if they've had outside studies or studies not kind of in your usual facility, you want to make sure that the measurements are being done the same way each time when you're comparing them. So we're going to first start with Marfan syndrome. This is an autosomal dominant condition. Aneurysms will typically involve the aortic root. That being around 10% of patients will present with a type B dissection as their initial aortic event, and they can get descending aortic and abdominal aneurysms. Imaging surveillance generally is annually with frequency dependent on the risk factors. So a family history of dissection, rapid aortic growth in a year, which is defined as 3 millimeters in a year, diffuse root or ascending aortic dilatation, if they have marked tortuosity of their vertebral vessels. Those are all features that will mark them as higher risk of having an aortic dissection and may push you to image them more frequently. So all of these flowcharts are based on Class 1 or Class 2 guidelines from the recent 2022 aortic guidelines. And so I just made these to try to simplify them as opposed to showing them in large text form. So in Marfan syndrome, once a diagnosis is made, generally you want to start with an echo as well as a CT or MRI so that you are ensured that you can adequately see the entire aorta. If on echo, you feel like you see the root in the ascending aorta and there's nothing else seen on CT or MRI, you can follow up in 6 months with just another echo. However, if you can't see well, you should use another CT or MRI. If it shows that the aorta is normal or smaller in size, you can continue following annually with an echo. If their aorta is larger or they have significant growth from baseline in the 6-month interval, then, quote, the guidelines say more frequent imaging. They don't define that, and so that should kind of be personalized between you and the patient and based on their risk factors. You are not done after they've had their root replaced in Marfan's. They still can have other disease in other locations. And so generally the guidelines recommend immediately after root replacement annual CT or MRI. If it's a normal diameter and stable in size, you can space that out to every 2 years. If it's enlarged or growing, again, quote, more frequent imaging. So it's important to remember to keep following these patients even after they have had an aortic surgery. Moving on to another familial aortopathy, this is Loeys-Dietz syndrome. It's also autosomal dominant. They have often similar features to Marfan's patients, although the tall stature is not associated with them as much. This bifid uvula is very common and diagnostic in Loeys-Dietz. They have hypertelorism, soft velvety skin, easy bruising, wide scars. Talking about their vasculature, they usually have very tortuous vessels, often in the head and neck. Aneurysms can occur in any artery, but most of them will have aortic root aneurysms that will lead to dissection. They have very aggressive vascular disease, and historical studies have reported a mean age of death around 26. The risk of dissection in these patients is present with even lower diameters than we classically think about. And then in terms of thinking about what individual's patient risk is, it depends on their specific genetic variant, the severity of their extra-aortic phenotype, the degree of their arterial tortuosity, aortic growth rate, and family history. So in these patients, again, you will start out with an echo. Here, the CT or MRI at baseline should be from head to pelvis. You want to image their entire arterial vascular system. At that point, if you identify that they have no arterial aneurysms or dissections anywhere, you can then continue to survey them, usually chest to pelvis every 2 years and head to pelvis, and then add a head in every 2 to 3 years. If they have a dilated or dissected aorta and or branches, you should annually image all of those involved vessels. For looking at the root specifically, they do recommend, again, a repeat follow-up in 6 months with an echo to see if it's stable in size in that time. If it is, then you can continue just to follow with annual echoes for the root. Granted, if you're already getting annual CTs or MRIs, you probably can forgo the annual echo. Vascular Ehlers-Danlos, we've more recently discussed EDS, but vascular is a very aggressive form of vasculopathy. It leads to spontaneous aortic and arterial dissections, aneurysms, and rupture at young ages. The onset and severity will correlate with their specific pathogenic variant, and imaging, like in other diseases, can identify the segments at risk. However, because this is rare, the surveillance frequency is still uncertain, as which we should how often we should screen them, and surgical repair carries a increased risk because of the vascular fragility of their vessels and associated bleeding complications. So we even don't really have good data to guide diameter thresholds for prophylactic surgical intervention, but rapid growth and obviously acute dissection would be an indication for surgery. These are general recommendations from the 2022 guidelines, but they do not have real data to support this. So these are not kind of backed by class 1 or class 2 guidelines. But generally they say you should image them from head to pelvis at diagnosis. If they don't have any abnormalities, continue imaging them from head to pelvis every 2 years. If they have any aneurysm or dissection present, you should do annual imaging of the involved vessels. Turner syndrome is another inherited condition that can cause cardiovascular defects and aortopathy. This is when a woman is missing one of her X chromosomes, so she's XO instead of XX. About 50% of them will have cardiovascular defects, whether it be a bicuspid valve, coarctation of the aorta, or aortic dilation, and some of them will have all three. Risk factors for acute dissection will include their aortic diameter and whether they have concurrent hypertension, bicuspid valve, coarctation. Notably, in this population, they are usually of very short stature and smaller than kind of what our guidelines usually use for normal cutoffs. And so the aortic diameter specifically in them should be indexed to their body surface area. This is recommendations on how to approach them for imaging and interval screening. So once they kind of reach teenage years, they should see a cardiologist, have a full echo, and a full cardiac MRI. In this case, we recommend an MRI over a CT so that you can assess for bicuspid and coarc in case if the echo is not adequate, because you want to know if they have those at time of kind of initial evaluation. If they don't have any of those associated risk factors, then you can see based on the size of their root determines what their risk of dissection is and how often you should image them. So if their root is small, less than 2, and they have no associated risk factors, you only have to image them every 5 to 10 years. However, as the root gets bigger or as they develop risk factors for dissection, such as if they develop hypertension over time, that will increase the frequency with which you image them. And then last but not least, we'll talk a little bit about the bicuspid aortic valve. So this is pretty common and affects 1 to 2% of the general population. Of those, based on kind of the study's definition of an aortic aneurysm, estimates range from 20 to 84% will develop a thoracic aortic aneurysm. This is Arnold Schwarzenegger, probably one of the more famous people who's come out to say he has a bicuspid valve, and this is him after getting a Ross procedure in the hospital. They will usually have aneurysms affecting the ascending aorta most commonly, but it can also affect the root, and the prevalence of aneurysms will increase with age. So again, starting out, you want to start with an echo. The guidelines say if you can see the entire course of the aorta, so root, ascending, arch, descending, on the echo, that is adequate. I will say I rarely get an adult echo where I feel like we've comfortably seen all of those portions of the aorta on just echo alone. So if you don't see all those portions, you should get a CT or MRI of the thoracic aorta at time of evaluation as well. If they have normal diameters, you can re-image every 3 to 5 years with the modality that is best for the patient, whether or not you have good echo windows or not. If it's in the 40 to 49 millimeter range, image every year. But if it's stable after imaging in a year, you can kind of spread that back out to every 2 to 3 years again. If their aorta is large, which some might say 50, instead of annual imaging, you might want to go pursue surgery, but if it's large, at least annual imaging in kind of the 50 to 55 range. Sorry, it's not. And then post-surgery, a CT or MRA can be performed to establish a new baseline after they've had it, and then ongoing surveillance intervals should be individualized for the person based on the clinical, anatomic, and surgical features of the patient and the particular operation they had. If they have any residual aortic dilatation or pathology, we should re-image every 3 to 5 years with CT or MRI. So, in summary, patients with familial aortic disease are at high risk of lifelong aortic events and thus require lifelong surveillance imaging. There's a variety of imaging modalities with pros and cons for each one. Consider MRI for routine annual surveillance over CT if you're able to limit lifelong radiation exposure. And it's important to remember that we are not done once they've had an aortic root surgery. Surveillance imaging is still necessary. Thank you.